It's my great pleasure to introduce to you Kim Galt. Kim is a graduate from the University of Michigan, pharmacist, and she completed her PhD in Lincoln, Nebraska. Her PhD is in educational psychology with a specialty in research methodologies. She is well-trained and has done a lot of work in qualitative and mixed methods. She's also been very well funded through AHRQ and has served on several AHRQ panels. I think continuously for, was it 16 years or something? Somewhere around there. She's been in the profession for over 40 years as a faculty, as in practice, and as an administrator, rising all the way through the ranks at Creighton, all the way up to VP of Research at Creighton. I had the pleasure of getting to know Kim a lot during Academic Research Fellows Program through AACP, where she was a master mentor and has become a great friend. So, welcome, Kim.
Hello. It's truly an honor to be here with you, and it's an honor to have been invited to have an opportunity to speak with you and visit your school. You may or may not be aware of this, but you come from a long legacy of excellence at UIC. This is an old program. It's established, it's got a tremendous reputation, and the way programs get tremendous reputations is through the excellence of their faculty and subsequently their student graduates who retain those values and continue to work hard towards excellence. That's really the only way it happens long-term academically. So congratulations to you. It's harder work later than now, believe me, and you will be great stewards for that. So it's with that I really do express my gratitude for being invited, and I am honored, and thank you, Dan, for inviting me, and Glenn for hosting me here, so I appreciate it. So, fostering patient safety research, a 20-year case study. I think today's opportunity for you could be, I would like you to analyze this case I'm going to present to you about fostering the science and research of patient safety to develop a better strategy for yourself as a scholar. To me, at this stage, real life's all about the narrative. The narrative is really your story. And so I realize I'm here to a very highly engaged scientific community who often is talking in language of evidence, defensible proofs, and other forms. But I am preferring to approach this presentation sort of by answering this question: what is my most personal story about fostering patient safety research over the 20 years? Because I do believe that it is there that you're going to find your own passion for why you will continue to work toward excellence and why you will pursue important questions, important aspects of inquiry, and what will keep you there when the lights go out, it's dark, nobody else is around, you're by yourself, and you're saying, why am I doing this? And why should I continue to keep doing this? So I hope you'll laugh with me a little bit and enjoy my personal approach to presenting about my work, because actually it is about my life. So let me start this 20-year case study with the main story begins in our nation in 1998. The phenomenon that we're talking about in this case is patient safety. The context of this phenomenon is that it became a nationally recognized problem that really peaked around 1998, elevated in importance because of simultaneous large stakeholder groups in the nation, such as the professions, such as Congress, and such as the media, who at the same time called attention to this problem. That led us to publishing the Institute of Medicine report, To Err is Human, and looking at media stories about Betsy Lehman of the Boston Globe and Ben Kolb, who died from minor ear surgery, and other stories. That's history that, as you study patient safety issues, is very engaging and very important to know. But the key problem was really that we had largely avoidable personal harm that kept happening commonly in healthcare delivery. Avoidable harm. And it continued to happen. Why did it continue to happen? And that's really what was calling to everyone. Why is this continuing when we can avoid most of this? Our response at that time in 1998, socially and scientifically, was that we were actually uninformed about the science of safety as a healthcare entity. We shamed people for things that went wrong. We blamed people for things that went wrong. We mostly did post-injury views of safety. Something happens, oh my gosh, something happened. We weren't preventive and proactive in our thinking. We were very litigation-centered. We're immediately going to sue if something's wrong, which further shut down all of our communication. So that's what 1998 looked like for us. So in this case, what were successes and failures, unforeseen results, and things that were inadequately measured during this time? Well, the problem was known. That's harm and injury, but really not how much. We knew it was big. The IOM report told us about 98,000 hospitalization deaths annually, and we had these kinds of big numbers, but we really didn't know how much in a local way. We didn't have a way. The causes were not known. We weren't paying attention to things like science of human factors, the science of systems, that had not crept into the language of healthcare. It was separate and distinct. We were at the same time getting new healthcare delivery, examples such as technologies. You have faculty here who are studying new technologies and their impact, such as Dan's work. And we were shifting paradigms to systems at the time. We really weren't systems oriented. At the time in 1998, where I really got interested in this, there were no electronic health records. Everything was paper, and we just got to the device, the personal digital assistant. Anybody heard of it? Well, we don't call them that anymore. I'm really asking you the question. It's sort of like asking about the dial phone. Does anybody know what that is? I mean, we moved well past personal digital assistants in our concepts. This went on eventually over the 20-year period to suddenly forming electronic health records, and then electronic medical records, and then regional health information organizations and health information exchanges. We had no idea what the results of implementing such things were going to actually be socially on our safety or on our improvement. So we had unforeseen results in this case, and we were without sensitive and specific measures related to the problem of harm and injury other than isolated events. So for example, if you were in pharmacy at the time I was, pharmacists who worked in hospitals would talk about medication errors, and we would count them. But the categorization of those errors that you might use at Rush Press would be different than at Cook County potentially. We weren't using common metrics, okay, but we were trying to do things. So what changes should we be considering in this case study for safety? We learned that we needed to describe in a common mental model what it meant to count harm and injury so we could talk about it all in the same room looking at the same picture. We needed to consider, develop, and test theories, which meant we needed to bring in the sciences of human factors, technology design, adoption, and use, the sciences of systems, to explain why injuries would actually occur, these avoidable injuries. And we needed to use this new knowledge from our science to develop improvements so that we could come up with recommendations for changes, such as implementing new designs, whether that's be for the technology, the process of care, the way we do things, or systems via a scientific approach, and then have the ability to be sensitive enough to measure the impact and outcomes that truly related to what we thought we were doing to achieve them. So this story on the patient safety world, this case story, it continues in 2016. So what I want to do is step back before I go into returning to 1998, which I'm going to do. But I still have to sort of answer the question for myself as a scientist, why did I want to research patient safety? Why? I could pick so many important problems and use these talents in different ways. So what is it that really drew me? And it did draw me deeply. I just was compelled. And the story really began earlier, and the story actually comes because of what happened to my father. And I believe this is truly why this engaged me so much. His philosophy was really that we are all here on earth to help others. What on earth are the others are here for? I don't know. But I had a life experience being raised as a child in a family that talked and approached things that way. So reaching out towards others in my science was probably a natural fit with how I already felt as a person. But I also really did introspect, and I'm encouraging you to do this. This isn't the story about me. This is a story about how I arrived at this decision, okay? And maybe you might do the same. You know, what motivates me is actually working in servitude to others. I think that's very good work. It's good work. And I believe in the worth of teaching others for the pure value of teaching and helping all of us learn more. And I do believe that research is a powerful tool when intended to have an impact of improving anything from a single person's life. So you will see individual case study research or the world. It's a powerful tool. I really am driven wholeheartedly to learn and apply. I'm ambitious about learning when there's a purpose for it. I have an insatiable appetite about learning something, and I'll tackle it until I feel like I really got it, you know. And I do push myself to the breaking point when I really care about something. These are good attributes in research, I want you to know. If you're like this will help you in research, as it will help you anywhere in life. But most important, I think, is I really do even emanate joy when I'm doing good work. Everybody knows it. You know, what are you so happy about today? And it really does come from my own definition of when I feel good about my work. So how does that relate to my father and me? So my father was about 35 years old when he went up into a tree and he was trimming branches with a chainsaw. Got kicked out of the tree. We didn't have a safety rope on. Wound up in the hospital with a form of a paralysis that was not permanent but was a very long-term recovery. During the 2 years of recovery, he was a 6'4", 240-pound man who was strapping, great sense of humor, and at the end of 2 years, he was under 100 pounds, emaciated, clearly starved. But why did that happen? When I was a teenager, I didn't have the knowledge I have now. So we just went along with the medical system, okay. Well, what happened was he never got diagnosed correctly for what his problem was, and they were looking for cancers. Why is he losing weight? They were looking for, he even got accused of having psychiatric disorders. He must be going and vomiting his food, despite no evidence. But at the end of 2 years, the big problem was we were out of money, and my family, first generation American born, my family did not believe in claiming bankruptcy. My family worked, and you paid for everything. You didn't borrow. We had no money left. They kicked him out of the hospital because he couldn't pay. So my mother, desperate, took him to the University of Michigan hospitals and clinics, which should have happened probably much earlier. As it turns out, he was starving to death, which is not a surprise based off his symptoms, because he had a gluten allergy. It was non-tropical sprue, and they never diagnosed it. And that led to permanent neuropathies, difficulty walking, and eventually his... But we did have parenteral nutrition at the time. In fact, parenteral nutrition arguably was commercialized at the University of Michigan, the very pharmacy school I trained at. When I came in as a student, I saw the big, huge vats where all the proteins were, compounded, and amazing. So he was almost starved to death. Misdiagnosis, definitely an error, perpetual error, of a magnitude that, you almost can't believe. How many other people was that happening to? Probably everybody under that physician's care in that hospital forever. Right? Whoever needed it didn't have it. So, and there are many other aspects to his case. And it had such a powerful impact on me that when I went into pharmacy, when I learned about parenteral nutrition for the first time, I went, oh my God, we have to be able to do this. It's an amazing personal impact. So between that and what motivates me to do other things, I think patient safety just drew me like no other. It became a compelling thing. If I can contribute in this way, I'd like to. So how will I contribute is the next question as a scientist. Some of us, will contribute by diving deep into a problem in a laboratory setting, deep into our minds, deep into the science of others. Little interaction with others possibly, be really creative, seeking the problem, solutions that we're looking for. In any case, some of us, if we're going to do that, need to think of ourselves as having a scholarly approach to things. So what does that really mean, to be scholarly? And I thought a lot about that, and I decided that in order to have a real impact in some way in science with what attributes I have, so you think about your attributes, what attributes do you have that you enjoy, that you think is good work? I like to teach. I like to impart new knowledge to somebody else. I like to discover it myself. I like working with someone else to do it. I like to collaborate and get a bigger impact. So I decided I not only wanted to work to facilitate patient safety through my own research, but I wanted to foster the sense of scholarliness about that in other peers that I work closely with so that we could really build a workforce together in patient safety research. And from the beginning of my own thinking, that emanated in my own thoughts. It's always been the picture I've had in my mind of not being alone, but working with others who share a passion and an interest. Scholars are essential sustenance to the long-term vigor of a university. Scholars exist to teach students, they exist to generate new knowledge. Faculty are expected to direct their own pursuits in a scholarly way at a university. And so with all of the challenges faculty do face in the environment, more today than I'd say back in 1998, I feel the pressure even greater. To have this displaced, I really feel strongly, it's probably an understatement, about the need to own this yourself and to achieve a scholarly way of life in order to continue to advance this knowledge. Because individually, I believe, each of us adopts, accepts, and says we're going to choose a scholarly life, and then we have to steward it. No one else does that for you. You own that responsibility. So can we learn why people become scholars and how persons achieve it? So I had an epiphany in my early life that made me believe, yes, we can learn why, and yes, we can achieve it. I really believe that the scholar integrates being a scholar as a way of life. And what happened was I had an early career job at a university, and to my surprise, I left that job after about 6 years, and I was kind of depressed, thinking I wasn't going to get to be doing scholarly work. Now, I was young. I didn't do anything near the complexity I'm involved in now. But I still had the passion for that, and it was before my patient safety. It was just about wanting to be a good research-oriented person. To my surprise, when I went into private practice work, I had the same skill set, and I tried to do the same things. When we had a question, if we couldn't, I'd go to the evidence in the literature. If I couldn't find it, I would set up a small experiment, or we'd do a little project to get our answer. If we had a stability question on a drug we didn't know before, we'd do a little experiment on stability right in the pharmacy. Integrating this worldview into the way I lived was the way I did my work regardless of where I was at. And I think that's been true throughout my career. I think you can learn it from others who emulate it, or you may naturally be oriented. Don't fight it. Pursue it. Develop it. I also had an epiphany somewhere down the road after I went back to academics. I told you I'd been 6 years. I went out in private practice, spent another 8 years that way, and then I went back into academics. And I had by then grown an ambition to have some kind of health services-oriented research. Hadn't arrived at patient safety yet myself before '98, but I did know that I wanted to do something that serviced people in my work. And so 2 universities, 6 years later, I actually did land my first federal grant in patient safety, which is when we go back to 1998. That's where we'll start. What is the point of this epiphany? Ambition with hard work towards goals less pursued reaps reward. It's saying when there's hard things to do, but they're worthwhile, you'll get to do them. Nobody else is competing with you for that. The hard work is something that people will happily let you do who have less ambition towards solving a problem or a goal. And that happened to me. We had a research center that I was a co-director of in medicine. It was related to health services outcomes. It was in another faculty line, at Creighton many years ago as a faculty member. The director wanted to quit. We were trying to develop people. We were trying to make this system be a good research system. And I was very disappointed he wanted to quit. So I stepped up and said, I'll do it. This is after 3 years of trying to find a director, trying to bring good packages forward and not having the university support really strong people. I said, I'm going to do it. I want to do it. He didn't want to support me because I wasn't a physician. Things like that happen, okay? I wasn't in the right profession at the time for their leadership role. So I said, well, that's not a good enough reason for me. Might be a good enough reason for you, but it's not a good enough reason for me. And so I put together a proposal, and I went to him and I said, last chance, I'm going to put together a proposal for a center at the university since you're stepping out. I'd rather work with you, and I'd rather have you be my executive, guiding me and mentoring me, and I'll be the active director. And he didn't agree. I put in the proposal, and we got funded. So you will be rewarded. That's hard work. It took a chance, but you will be rewarded at some point when you really are doing something that is worthy of pursuit. So once you do make a decision, I think the university or the universe conspires to make it happen, right? Okay, that all lined up. So back to the 1998-99 period. What happened was I had put in the proposal. I did receive a first federal grant, and it was in the area of patient safety. So I thought I'd switch gears now to just take us through this time period of the 16 to 20 years or so. And I'm just going to give you a few examples of projects and how that sort of fit with this other notion of not only doing the science and producing science that's, we hope, useful and makes a difference, but also working with others to enrich and have collaborators who are highly talented, and on how that came to be. The very first grant I got was an investigator award. It was before electronic health records, and it was called Impact of Personal Digital Assistant Devices on Medication Errors in the Primary Care Environment, the e-prescribing initiative. So our purpose was to determine the impact of PDAs doing electronic prescriptions in the local office. And we wanted to study a model that was possible in primary care, and we wanted to study a model that was affordable. So we designed one. And this is the intervention, we took a PDA which had the ability to do infrared transmission. We set up electronic prescription templates, worked with companies to backfill what the drug names were, dosing routes, etc., to populate an electronic prescription. And we worked with Lexi Drugs as a drug information resource to have it available on the PDA. And then we took the system out into 31 physicians' offices. And we asked them, will you play? We want to study what happens on your prescriptions if you e-prescribe for us. Now, it's not the same as e-prescribing today, is it, if you're familiar? E-prescribing's come a long way. Again, there were no electronic health records. So it was a 3-year study, and we collected 500 prescriptions per MD. We had about 40,000 prescriptions where we looked at the face of those for error measurement. And then we randomized the groups. And I won't get into much detail about how the science was structured, but we were going for a rigorous design for randomization so that we could reduce the noise in the background and the problems we might have with interpreting impact and effect. and we did the study. I wound up having 15 different faculty involved, which is part of the story early on of realizing there were highly interested people I could work with. It was my first discovery of, oh, really committed people who are interested in this. So it was some of my first what I'd call true partnerships with other faculty who wanted to learn and know, who had very different interests about this. And it let us structure some other questions in. We looked also at, therefore, the office technology assessment at the time. What were these primary care offices like? That they could, how did their workflow change because we introduced this printing device in and did this electronically? How well did they use the drug information resource on a PDA? You go into the offices and they weren't using electronic drug information resources in their hand, you know, so that was a big shift. And how well did they just adjust to using a PDA? Fat finger syndrome on the telephone is, you know, first showed up on PDAs, right? So we had a 3-year study where we built all of these things in. We learned, this is all voluntary use, right? They're not mandatorily, but we learned 43% of a potential 100 prescriptions were generated using a PDA in our study period. Not a long time, but gives you some overall sense of how many they could do, how many they chose to do, how many, there are some prescriptions they couldn't generate electronically because the format isn't good enough. Steroid tapers, for example, you know, that took a long time to even build in EHRs, okay? So we learned a lot about what the limitations were to trying to generate it. We looked at improvements. We saw a reduction dramatically in illegible signature, which you'd expect, but not to zero. And at the time, the patient safety culture movement was saying, if we could electronically prescribe, we'll have no errors. We'll be able, right? That was the big mantra. No, that's not true. Because there are a lot of situations. This is true today. It will continue to be true today in safety. You don't get to zero. That's your goal. But you don't get to zero because you introduce different entities into your system. But overall legibility went up dramatically. Errors of omission dropped quite a bit, not to zero. But because they were prompted to fill in a prescription with pull-down menus in the hand, and they had a drug information resource, which we counted, it made a fairly substantial impact on reducing those omission errors. Use of abbreviations dropped substantially too, although certainly not to zero. Here's an example. This is actually what it would look like printed out. You can see that if someone pulled the wrong route down, it would type the wrong route in, just like it does on your EHR today, you know. So pull-down menu errors are still a problem today. They were a problem then, and that's, you know, we discovered it firsthand and say, how many of those did we have? I know. It's kind of a dramatic example, isn't it? We also were interested in adapting and adapting to P. I said we wanted to know whether they would accept this technology, so we structured a barriers and solution design where we did the intervention, which is we taught proper use, we standardized their assessment. They had to get to 100% correct performance before we let the machines out and go, and then we studied the impact of that. And we came up with barriers and solution themes, which we used qualitative research approaches to do analysis on to produce those. And then finally, we did do some path analysis modeling on what were the factors that caused them to adopt and use or not use the technology. And here's a path model, post-intervention data that we could provide that showed what were the key factors that made them a user or a non-user of the technology. And then we also studied, you know, when we were picking the drug information product, when you do research that is founded in real world products that are for sale, those products are often not alone on the market. And we call that turnkey, right? We want turnkey things to use, right? Things that are ready off the shelf that you can use. Because if your intervention can use something that's already commercially available and it's good, why not? Because it generally means it's highly accessible typically if you do that. Well, there are 3 drug information products on the market. We tested them all. We tested them for quality and completeness in answering the typical questions. So we had a battery of questions for primary care physicians. We had them use the 3 different products and compare the outcomes. And we demonstrated to ourselves first, before we selected the product, which of the drug information packages at that time gave us the best outcome. You know, of all the research we did, which I find this to be something you could do as a really outstanding graduate student project to learn basic techniques on, and you could get this done in a reasonable period of time, this generated the most controversy. Do you know why? Can you imagine why? Why would this generate the most controversy? Yes?
You're dealing with companies that don't want their product to be less.
It's that simple. It is that simple. The companies were watching this real close. And I got invited to Johns Hopkins to present this, and Micromedics, Mobile Micromedics, was by far the worst product at the time, and I got hammered at my presentation at Johns Hopkins by the company. They really wanted to take me down in front of that audience. So very interesting what you can encounter when you're doing what you think would be relatively innocuous work to get to quality and excellence. Give me the best product accessible to providers at this time. We looked at the technology readiness. I presented this to you more for entertainment. You know, at the time we were doing this kind of work, operating systems and network systems and printers. Did they have an infrared enabled printer or not? We had to replace if they didn't. What was their internet package? So we categorized the technology of the environment of their office to see what the potential future was going to be for that. We were just on the verge in 2000 of hearing about electronic medical records. 2001, 2002 started some beta. You know, I go into these offices where we were doing, I said, wow, you're going to convert all that to electronic? At the time, these were 750. When eventually the first EHRs came out in the ambulatory environment for offices would tell us, I've had a quote to try to convert over to a first product. It's $750,000 to $1 million to do my office. I'm not doing it. You know, this is where things started. But some were building new places, and so they were preparing. So here's your data jack. What's it doing over there? I don't know. I was on tour in one site. We are proud of our new rooms. I requested a data jack in every room. See, where is it? They covered it up with the drywall. Maybe it's in here. I better call them. This is unacceptable. It was the first time we went to look to see if you had electronic access, you know, where the internet would be for your RJ45 cables. And he, you know, it was really entertaining. I mean, I'm on tour going, yeah, we are not ready in this environment yet out here for electronic transmission. Basically, medication safety was missing as a true governing concept in primary care office-based practice. When we got all said and done, it wasn't there. And now it is much more present because of the ongoing 20 years of research. But it wasn't there then, and so we did some early mapping in our project of, well, okay, let's talk about the prescription and how, you know, medication information travels with the patient and to the physician and to the pharmacist. Where's every opportunity we have for something to go wrong in a pathway? So here's an early pathway example of where we first tried to map that so we could better analyze our problem data and say, well, where could we make a difference? And eventually we generated some specific recommendations. All these publications outline the early results from that work. Most of the publications we put into the Advances in Patient Safety from Research to Implementation, which were peer-reviewed articles that went into AHRQ's published books to disseminate in all kinds of environments, which they have subsequently changed. But of course that drug information paper was in the Journal of the Medical Librarians Association and gets cited all the time and was the source of companies calling us about it. At the time, I really did find that we were headed in directions in this work that probably were, what would I say, you know, many people weren't headed in this direction with their work. It is hard to go out in the field. To this day, people say, how did you actually do 31 offices? How did you do it? In fact, AHRQ called us after 2 years and we're producing data and said, would you like to form a practice-based research network for us? You know, which is a very different model, but they said, you've got that many people playing, you know, why don't you do it? There are reasons to not do that where I'm at. But the way we did it was actually with students and faculty. We hired 31 students on that grant, and we put them through 4 weeks of training, rigorous training programs on professionalism, how to speak in the office. Like salespeople get prepared in the pharmaceutical industry, we did the same thing. We tested them on, do you know how to use these abbreviations correctly? What do they stand for? Do you have your, you know, do you have your, and then we gave them all laptops, and we gave them, at the time, discs. That's what we had that you popped in. No such thing as a USB drive yet. And they went out and collected the data in the field and brought it in, and we had whole processes. I needed to set up a computer network for it, and so I had a colleague who was great at it. We built a computer network with 8 data entry stations, and they entered the data into our core server. All that was what you did as a researcher then, you know, which is very different now, I think. But you'll be doing that same kind of thing with your innovations in the areas you head into. So I'm here to tell you another epiphany in this is make sure you know what you want, because once you decide, you'll probably get it. And so we, after that really wonderful first experience with some failures and some successes, we now had a group, a working group, and we set out to apply for more funds to take some of our findings and move them forward, and that's what we did. And we got what was called a BRIC grant, and it's Building Research Infrastructure Capacity. It's the perfect grant for what I cared about, because the BRIC grants had 2 pathways. One pathway was competitive national research that stood up to scrutiny. Your project had to compete and contribute nationally for the agenda of the sponsoring agency. But we had a development pathway for everyone involved. The purpose of their involvement was to become better at whatever the research skill set was that they wanted to develop in. You may have heard of K awards in the NIH tracks. BRIC is like a K award on steroids. We had 7 faculty members now on there, and we had a development plan for each of them that went and matched the research project we designed. 2 years. So everybody in the group went to Wisconsin SEEPS program for studying patients, engineering and patient safety, where human factors and systems and design is taught in concentrated coursework. All faculty attended that. We all attended together, and we came back and we studied together. And then we had different courses in different places. One of the places was the University of Nebraska-Lincoln. I went to the University of Nebraska-Lincoln before I had my PhD. This is the time I didn't have my PhD and I was doing this. And I went to see the chairman over Research Methods Division there in Psych Ed. And I said, we have 7 faculty members and you have some fabulous courses, and I want to know if I can secure you to let our faculty take these courses, or can we set up an arrangement and pay you? He said, yes, if. He says, what are you going to do? And I said, I'm going to run this grant. And, you know, and he said, well, I need you to get your PhD. And that's actually how it in essence went down. And I was because I was so excited, I was going to take most of the courses anyway, and he talked me into that, which wasn't much talking. I really did want to do it. And so I had worked on advancing my skills as a research methodologist. So I said, you know, I always wanted to be somebody. I should have probably been more specific. That's what I wound up being, a research methodologist in that stage. So this BRIC grant was to develop both faculty and infrastructure. And so these were the individuals all on the grant. These are the people. This woman, Angela Drinzik, is a physician. Dr. Karen Pascal is a doctorate in physical therapy. Dr. Mark Syracuse is a PharmD PhD, Minnesota PhD grad. Amy is a nurse and a PhD, and she has a statistical methods PhD from UNL. And J.D. Bramble, who is a health services research PhD out of Virginia. Bart Clark, some of you, he's an alumni of your program. So this was our research team. This is Ann Rule. Some of you may know Ann Rule from past history in ASHP. She's very involved in it. She's a pain management specialist, and she did a fellowship in patient safety outcomes. So this became our group from all these different disciplines who we met weekly, and we had development plans that we followed for the 2 years. Okay. It doesn't want to move. Let's see if that helps. Yes. Okay, so we had a team. So we went from a collaborative concept of a good working group to, we have a lot to get done. We need to organize in a more structured way to get our science done. Because we have a lot of learning to do in order to feed our science, and it's integrated with each other. So we have to all stay on track. We really needed more of a team approach to this. And so I said, okay, I'm just going to go look all that up in the literature, and I'm going to get us guidelines, and we're going to follow the rules, So I did. And you know what? There's just thousands of papers about teamwork. There's a few key scientists, Kralewski at Michigan State, for example, in Washington. There's a few key scientists who really have done a lot in theory. There's nothing but case studies about teams in academic research. Nothing but case studies, no really major work done. And so I did my PhD on that. I studied 4 health services research teams that had been formed that were ARC funded, and I did in-depth grounded theory, qualitative analysis, and I developed a theory on how do individuals succeed when they participate in research teams. How do they do that? What is the process of success? And that was how I try to contribute back to our team, and it was helpful. But I'm trying to show, I guess, what I'm trying to illustrate is, as time goes by, your own development guides you to new kinds of learning, new kinds of realizations. Maybe others saw that and I didn't, but you do evolve and mature through new ways of seeing things as you grow through it. And it's a very exciting thing. And so the scientist challenges in our group that you face when you're doing work is they had to develop a clear concept of their own self-career trajectory. And we needed some time together to really get a sense of what is team formation, as opposed to we like each other a lot, that's why we're working together. And we like what we're working on, that's why we're working together. But what do we do about making sure that the weakest link gets picked up and carried over the sand when things aren't going right? What do we do when there's really strong differences of opinion about how to proceed on something? How will we agree on some rules for behavior so we will proceed successfully? So we don't lose anybody on the team. So we don't abandon anybody because we have disagreements. So that we have mutual respect all the way through. And those were the challenges that we faced, and to this day, we are still part of a research center together, so we made it and continue to make it. But teamwork, we knew this already intuitively, and all the literature on teams tells you need more time to develop together when you're a team than individually. You can proceed more efficiently individually. And so that meant that was going to slow research down. So, and everybody talks about this now. It's now common to talk about this because team science has moved forward so much that you can read a lot about this. Before, at this time, I didn't have that to read. And so you have to come to terms with how you're going to deal with the increased time for relationship development and what that means to your research. I can tell you what it means in the outcome is a fabulously better product, well thought out, particularly on complex problems where I don't care how smart you are, and most of you are probably smarter than I am. I'm okay smart, but I'm not brilliant. And it's still not good enough for really complex problems. You get humbled by the brilliance of the different viewpoints that come to the table on a problem. how problems get redefined together because you're working together. And you thought the problem was this, and now you have a clearer sense of what the problem is, and you've redefined it. It's a very powerful way to proceed. If you get that beautiful opportunity, I hope you get to take it. So we did a lot of revising. So I'm sorry if you were right. I'd agree with you that we had a lot of these kinds of conversations that went on. And at points, I was the team leader, so I knew this was on the minds. I kind of went with this philosophy. I'd just sort of be available at times when we really got into tense areas and let people's work emerge, and ultimately we would reach, we had rules for consensus. We had rules for disagreement and how we would approach them. The outcomes were great. Their growth and accomplishment of the individuals is shown here. I'm just showing you, by the book, the numbers of abstracts and manuscripts and federal grant reviews that went on and submissions over time with these individuals and where. And we had detailed plans during that about what each person was going to apply for and how they were going to do it. So this is just an example of, how we would get to concrete for everybody. And then this was our mantra. I love deadlines. I like the whooshing sound they make as they fly by. Resetting. We didn't abandon deadlines, but we reset them a lot because of the complexity of trying to do it. And then finally the third federal grant, which was called the Sustain Grant. And what happened with the BRIC Awards were, it was a limited competition. So if you're learning about funding opportunities, there's open competitions. Anybody can apply if you meet the criterion. Limited competitions are, you've already received some kind of award already from the sponsor, and so they're closing the number of applicants down to those they previously have successfully awarded. And that means only a few of you are going to get those, and some of you won't on a limited competition. And so we were fortunate enough, we were one of two to get the limited competition award for the next one. And that was called the Sustain Grant. So that was the third federal one. Now that went from our team to 3 research projects and 3 teams, and the development of a center model. Now you have a prior success story, Dr. Schumacher, who had a center in the DECIDE program with ARC, so you really have people to talk to here about what that experience is like. This was a major change to go from an effective team to multiple teams in a center. So we mapped our strategic development more along what the activities were. Center challenges, within our university, we had to educate people. We had to create an institutional vision. We established relationships without walls amongst people, and we secured funding to support sustainability. Over the years, by the time we went through those first couple of really big projects to this multiple projects and safety going on, this is financial data, and what I learned to do was show data to administrators about submissions and awards and returns on investment, which I didn't care about at all when I first started into the science. And I do care now only to support the continued good work that people are doing. But it became a new set of tools and a new way I had to learn to talk to people to get their attention, right? And then we had scholarly productivity. Some of our universities really went, and this was, for me, beautiful. Over the 6 years, there had been 66 publications, 84 presentations, 47 grant submissions, 28 awards. We had a 60% award rate at that time. It was just fabulous, Not all large and small, all comers that were high quality, that met our agenda, was good money and good projects. And I actually have a list, I have examples of that, if you would like to see examples. This is a newsletter we put out at the time. It's look and pitch type of stuff. It's not bad, it's resource. But just to go, we had short lists and long lists of large grants and small grants and who was going for them. And then we kind of tried to look at the cycle of research and how our economic productivity indicators matched our scholarly work, and self-studied that way. But some of the most important indicators to me were what happened with our faculty peers, the group that I was working with. I became the first person at our university, unlike yours, which is a highly funded and a highly sophisticated place, with a lot of knowledge in your infrastructure and administration along with your faculty. We didn't have that where I was at. So I had the first AHRQ award ever for our university, and they didn't know what to do with that. So I had to become knowledgeable about helping our university. And I was the first grant reviewer with ARC ever at our university in a study section. But to me, what's so satisfying was by the time I was the first reviewer in 2004, by 2012, 7 of us were doing grant reviews and study sections. Now, that is an experience to talk about with your faculty if you are not familiar with it. The study sections is the peer review process for awarding funds, competitive grants. It's a highly educational, highly intense, very hard work, but it's honorable, it's important, it's almost like tithing to your scientific community by contributing back in that way. But these faculty learned a tremendous amount, we all did. And we went from being on one review committee during the year to 27 different meetings people were going to for reviews at our peak. It's a pretty terrific thing to claim as an individual, that you are regarded as having enough expertise to do that work in peer review. Then we got to that point, and we had a lot of publications coming out about safety, and we had a lot of projects coming about safety, and some of those are on that list. Today's talk wasn't really to review all that science, I guess. But we kind of then asked, well, what should we do next? Here we are operating kind of at top speed, and how can we better do what we're going to do now? And George Carlin says, well, you always do whatever's next. I mean, that's what you do. And in all seriousness, the epiphany then became, I am leading others, so I must be careful where I lead. And I never felt like I was really leading until I reached that point where I had a realization that I was leading our group of peers. And so I made a decision, that, you always want to look to go where you will want to lead others. If I want to go there, others may want to go there too. So there's much science published that we've done. I hope you take a look at some of the areas of interest we've been involved in. But now what I want to suggest to you is that you look at this case study I just presented you. These are the typical steps of analysis in a case study. You may recognize when I first introduced the case study of patient safety, these were the key elements I put up. What is the phenomenon? What is the context of the case? What is the key problem in the case? What has been the response? And so on. And when I look across the 20 years of what's gone on in the patient safety movement and its research, the phenomenon remains. Patient safety is still a major issue. The context has broadened to be more complex, not less. We now have brought in many technologies into many environments in more complex ways. We've changed fiscal policies and all kinds of things. So the key problem remains harm and injury. If you go over the 20 years of history, I lecture, I teach on this, many of us in the group do. We hold seminars, we have annual meetings about it. You look at the data, and all of the major efforts that have been made in data collection still suggest that we've gotten better at counting it, better at defining it, capturing it in more areas, and we're not seeing substantial reductions. Why? Maybe we're doing great because of the number of complexities we're introducing into systems. Maybe we're actually doing well, given how much more complex it's gotten. These are really difficult areas. But I do know there's lots of room for improving people's safety still. And there have been many fabulous practices and interventions introduced that you should have learned about in your programs or do need to learn about as you're proceeding on in your profession that all need to be adopted. But it hasn't brought us to zero. And with all of the new changes, we are still challenged to say people are safe when they go in for health care. And so I'm enthusiastic that there's a baton to be passed to people who would like to pursue this area find the passion in it and want to engage. And I would encourage you, if you find this area of interest, to realize it is ripe, it is fertile, and it is needed for people. So I'd just encourage you at the end here, could you compare what was revealed in any aspects of what you heard today about this into what you might improve in your own scholarly efforts in your work? And I think that's I hope the takeaway from this is that maybe there are some things that were brought up that would be of personal value to you. I do think that being yourself in this world is constantly trying to make you, where someone's always trying to change who you are and get you to conform is one of the greatest accomplishments. I feel best about the fact that I stayed true to what I cared about the most and I know I worked hard to do the best I could within my own personal limitations. And I hope that, as you get to this kind of stage in your career, that you feel that same way about whatever initiatives you've taken. It's been a pleasure to be here with you today, and as I said, you come from a great place, so you have something to carry forward when you leave.
I think we have time for one question. Does anyone have a burning question after all this? Does anyone want to compare their path to where they'd like to be?
I feel like a loser now.
Oh my God. Why? Well, that wasn't supposed to happen, and you have absolutely no foundation to say that, I know, about your career. You have no foundation.
All right. Well, thank you, Kim.
Thank you.